So we are now in the pathophysiology and pharmacology of cystic fibrosis. And cystic fibrosis is known to be caused by a mutation in chromosome 7. And in chromosome 7, we have these genes that provides instruction for making proteins. And one of these genes is called cystic fibrosis transmembrane regulator, or CFTR protein. And it controls or regulates the channels of sodium and chloride ions across the cell membrane as per Patton et al. 2024. So to have a CF, you must inherit 2 copies of mutated CFTR gene from both of your parents. So when both of your parents are carriers, there is 25% chance of having a child with CF, while when one has CF and the other one or the other parent is a carrier, there's a 50% chance of having a child with diagnosis of this disease as per cystic fibrosis Tasmania. And as you can see in the chart, even if both parents are carrier, it still doesn't mean that you will have a child that is diagnosed with CF or cystic fibrosis. So understanding CFTR channels, I would like, before we continue with the pathophysiological process, our bodies have a defense system called mucociliary system, wherein the pathogens stick to the mucus and the cilia of the cells helps to sweat it out of the body. Also remember that both chloride and sodium ions has to do with balancing the body fluids across the membrane. So with CFTR protein, it allows the chloride ions to move in and out of the cell. In cystic fibrosis, CFTR mutated gene can make it in a different shape, making it hard for the ions to pass through, or here, yeah, or the CFTR may not even be in the membrane. So it means there's no passage for the ions to come in and out. Aside from that, a broken CFTR protein increases the activity of the ENOC, or the epithelial sodium channel, which means it allows sodium ions to enter the cell that results in increase of water inside due to the increased sodium concentration. So it's like the osmosis, making dehydrated secretions, which makes the thick and sticky mucus. We can remember the thick and sticky mucus. This thick and sticky mucus is also an environment for the bacteria or the infection to grow. So CFTR protein are also found in the digestive ducts, which allows the enzymes from pancreas to digest important substances such as fats, proteins, and vitamins. So with cystic fibrosis, the buildup of the thick and sticky mucus, the enzymes are blocked in the pancreas, and it cannot do its job properly to digest this substances. It may cause malnutrition or damage in the pancreas, which may alter the ability to control blood sugars, which may also cause diabetes. So the CFTR is also available in sweat glands. So CFTR protein allows chloride ions to come into the cell. With CF, or cystic fibrosis, the altered CFTR protein channel blocks the chloride ions to come into the cell, which allows to combine with the sodium ions in the sweat glands. This results abnormal salty sweat. This abnormal salty sweat is also used to diagnose cystic fibrosis. To summarize, the mutated CFTR gene causes no CFTR protein in the membrane, or with CFTR protein but in different shape, which means it doesn't function properly. So this defective ion transport may affect the integumentary system. As mentioned earlier, the opposite charges attract, so less chloride reabsorption means also less sodium reabsorption. Aside from that, it may also cause low volume concentration or dehydrated secretions, which can produce mucus plugs or impairment of the mucociliary clearance. This causes mucus obstruction, infection, and inflammation. This affects our respiratory, digestive ducts, liver, and intestine. So with our pharmacology, CFTR mutations has different classes, and class 2 or F508 delta is by far the most common, as there is 80% or more patients have this mutation as per Deboek et al. 2014. So Trikafta is one of the medications that is given to the patients diagnosed with cystic fibrosis. Not, Nonetheless, it is specifically indicated for patients with this class mutation as per Department of Health and Aged Care 2024. So as per Cystic Fibrosis Foundation, this medication is also approved by the FDA to administer to children or young adults with this mutation. So information about Australian Medicine Handbook. Trikafta is a combination of elacaftor with tezacaftor and ivacaftor. These are CFTR modulators, and the mode of action of elacaftor and tezacaftor is that they increase the function of the CFTR protein in the cell surface. Then the ivacaftor allows to increase also the function of the channel openings for the chloride ions to pass through the cell membrane. So with that, um, it m- it may able to the CFTR and the ENOC will be able to function properly, which means reabsorption of sodium and chloride will happen. Aside from that, um, there will be hydration in secretions already, which means cilia will be able to excrete mucus out of the system. It means no thick and sticky mucus, which results no obstruction or no environment for bacteria to grow or no recurrent inflammation. Aside from that, without s- without or no thick and sticky mucus, enzymes will be able to travel to the digestive ducts and do their job to break down nutrients properly. Here's the references for our pathophysiology and pharmacology of cystic fibrosis.